There you are. Okay. Is that good?
Good, excellent. Go ahead.
Okay, so I'm going to, I know that Dr. Yasser and Dr. Retrosi talk a little bit about diaphragmatic hernia, and I know we are behind in time. So I'm just going to try to focus only on the respiratory management of congenital diaphragmatic hernia for reasons of time. So I have no conflict of interest to declare. So we know that infant with congenital diaphragmatic hernia, they have one of the components of the diaphragm has not formed properly, and it has created a defect that allows the abdominal content to enter into the thoracic cavity during fetal development. And that creates a lot of issues for the lungs and the heart. So the incidence of diaphragmatic hernia is about 1 in 3,000 deliveries, maybe more or less according to where you are. There is associated with different degrees of abnormal lung development. I'm going to try to squeeze this, okay, of which the most important one is pulmonary hypoplasia and pulmonary hypertension, as we're going to discuss soon. And this is extremely important. It requires an integral multidisciplinary care across 3 distinct phases: prenatal, perinatal, postnatal, and childhood adolescent. We know that the mortality of congenital diaphragmatic hernia has decreased significantly over the last several years, mostly due to a much better ventilation management, and also delaying surgery has helped to improve survival to about 60 to 70%. And in cases of isolated diaphragmatic hernia, the survival goes up to close to 90%. Now, this improved survival has also increased the frequency and the severity of morbidity among survivors. So that's something important that we have to consider. So congenital diaphragmatic hernia can be divided according to the location of the defect into posterolateral, which is by far the most frequent one, anterior or Morgagni, and central. The posterolateral or Bogdalek hernias account for about 70 to 75% of the cases of diaphragmatic hernia, of which the left side is by far the most common one. The anterior hernias account for about 20, 25%, and the centrals are very, very rare, and only 2 or 5% of the hernias are central in origin. So what's the pathophysiology of congenital diaphragmatic hernia? Well, first we have pulmonary hypoplasia. We have the abdominal content going to the chest and is compressing the lung on that side during the very early stages of lung development, especially during the saccular and the canalicular stage. And that causes a lot of issues for lung development. It causes decrease or stop in airway development, decrease or stop in alveolar development, and that causes a significant problem when the baby is ready to be delivered. So we have decreased airway branches, we have decreased gas exchange, surface area. The other issue that we have is significant pulmonary hypertension. Now, the pulmonary hypertension is due to several factors. One of the factors is because there is a reduced total number of vascular beds. There's also a vascular remodeling that occurs in utero. But also there is a component of altered vasoreactivity that is most likely related to an imbalance between vasoconstrictors and vasodilators of the pulmonary circulation. Now, the first 2 factors make this pulmonary hypertension irreversible. That's the part of the pulmonary hypertension that is not going to be able to be fixed with medication. And that most likely will determine the survival of the infant or the long-term morbidity, the degree of pulmonary hypertension that is irreversible or fixed. Now, the altered vasoreactivity is reversible, and that's the part that we could modify with our medications, either nitric oxide or sildenafil or other pulmonary vasodilators that may decrease the degree of a reversible pulmonary hypertension. And finally, it's not just all the lungs. We also know that there is an impaired cardiac function in babies with diaphragmatic hernia, especially with the left ventricular function. Many of these babies have decreased left ventricular function that causes increased left atrial pressure, and that causes also some degree of pulmonary venous hypertension that will actually worsen the abnormal pulmonary blood flow. So this is something that you have to check with echocardiogram or a TN echo after the baby is delivered to see the degree of left ventricular dysfunction. So it's extremely important when you are dealing with a baby with diaphragmatic hernia to be well prepared. There is to be a good coordination of all the people that are going to be at the delivery room to provide the best care we can to these babies. And it's very important that the most senior personnel, nurses, RTs, and neonatologists are present at the time the babies are born. So the pre-briefing that we do a team huddle, we discuss the plan of care, we define the roles of the different team members that we present in the delivery room. We want to be sure that we have all the supplies, everything that we need for equipment and medications for the baby. And also we make a plan to see how we're going to transfer this baby from the resuscitation room to the NICU. So this part is extremely important. Now, what are the immediate goals of the management of babies with diaphragmatic hernia after delivery? The most important thing first is that you need to avoid high airway pressure. It's very tempted to try to see if we can get the SATs up right away. But if you're going to do that, you're going to have to use very high pressure. And that's not the priority. Okay, the priority is to protect the lung from the first breath. Okay, so avoid high airway pressure. The second goal is to establish adequate perfusion and oxygenation. And third is to maintain blood pressure in normal range according to the gestational age. I know that Yasser already talked about perfusion, a little bit of oxygenation, and blood pressure and hemodynamics, so I'm not going to touch into that area now. So the type of monitoring you need the delivery for this baby is you need to, of course, monitor the heart rate. You need to have a pre and post-dactyl SATs measured continuously. You want to ideally have a continuous intra-arterial blood pressure monitoring. Usually this is done by having a pre-dactyl radial R line to get pre-dactyl gases and also to monitor blood pressure. But you can also have a UAC to monitor blood pressure, and ideally either have another R line in the radial artery or just rely on your pre-dactyl SATs for oxygenation. Blood gases usually need to be done frequently, especially in the first few hours of life, just to be sure that you are not underdoing or overdoing your ventilation. And it's also extremely important to do a chest X-ray to see how well the lungs are expanded and the position of your tube as soon as you intubate the baby. So the things that needs to be done immediately and things that they don't need to be done immediately are as follow. Delay cord clamping in these babies, although it's controversial, at the present time is not recommended. These things may change. I guess the idea is to prevent the baby to have a lot of spontaneous breathing before we put an NG to decompress the stomach. However, physiologically, it make more sense to wait until at least the baby takes 1 or 2 breaths before we cut the cord. Maintain thermoregulation. Placing an oral or nasogastric tube with continuous intermittent suction is crucial, and that should be done right away. And the baby should be kept NPO, as we discussed before, until the time of surgery. A central venous access, usually a UVC, is very important to be able to provide medications and fluid. And as I said before, ideally, you want to have a pre-dactyl arterial line to monitor blood pressure and pre-dactyl gases. And IV fluids should be done very cautiously. usually recommend having these babies on fluid restriction, no more than 60 to 65 c6 per kilo per day of D10 in water, and have a very strict fluid balance, at least until the time the surgery is done. Now, in terms of intubation and ventilation, as I said before, one of the things that you need to avoid at all costs is bag and mask ventilation, because most of your pressure, most of your flow will go into the stomach and will make lung expansion more difficult in the chest. So try to avoid bag and mask ventilation at all costs. Immediate intubation is recommended. You don't have to do it at the site of the mom's delivery. You can take the baby to the recess and do it properly there, but it needs to be done quite quickly after the baby is delivered. The next step is to, as I said before, to avoid high airway pressures and provide gentle ventilation. Now, what do I mean by gentle ventilation? It's first is to see if you can avoid peak inspiratory pressures up to no more than 25 millimeter mercury. There are some centers that allow that pressure to go up to 28, and sometimes you need to go 28, but ideally you want to keep those pressures under 25 millimeter mercury, at least for the first few hours of life until you get a better handle of what's going on. In the first 2 or 3 hours, you don't need to aim for a normal black gas. You don't need to aim for SATs in the 90s. Usually what we do is we aim for a pH that is 7.0 or a bit higher than that, but not much higher than 7.25, 7.23. A PCO2 less than 65 is more than adequate. And the pre-ductal SATs usually should be okay for at least 2 or 3 hours, just above 80%. Don't try to aim for SATs in the 90s in the first few hours. The post-ductal SATs, again, in the first 2 hours of life, it could be also acceptable if they're just above 70%. So this will help you to minimize the exposure to high pressures and high oxygen in these babies. Now, we know that the initial mode of ventilation is very controversial. Right now, there is no indication that these babies should be prophylactically started on high frequency ventilation. The recommended mode of ventilation right now is ACVG as an initial mode of ventilation, and only go into high frequency as a rescue if the baby fails. In our unit, we use ACVG, and we switch to high frequency ventilation if the PIPs exceed 25 millimeter mercury to maintain CO2. Surfactant is not indicated in this infant. There is no rationale for giving surfactant to these infants. Now, if you're going to start this baby on conventional ventilation, what we usually recommend is, as I said before, the ACVG mode. The rate should be set usually high, around 60 breaths per minute. The volume should be set at around 4 mLs per kilo. Now, some people say, well, but you're only ventilating one lung, so you should actually have a volume less than 4. The problem with that is that the amount of CO2 the baby is going to produce is the same. Not because you have 1.5 lung or 1 lung, the CO2 production will be less. So your minute ventilation should be very, very close to a baby that has 2 good lungs. So it's going to be extremely difficult to try to ventilate babies with a volume of less than 4 per kilo. So usually we recommend a volume of 4 per kilo, regardless of how much lung tissue you're dealing with. The PEEP should be adequate to maintain the lung open, and that should be assessed by the degree of oxygenation and by your chest X-ray. Usually in these babies, a PEEP to between 5 and 7 is more than enough. The inspiratory time should be set according to the flow waveform. You should always look at the flow waveform to adjust your inspiratory time according to what you see in the flow waveform. In general, most of these babies will need an inspiratory time of about 0.35 seconds. But then again, that could be adjusted up and down a little bit according to what you see in your flow waveform. If you decide to switch this baby to high frequency oscillation because the conventional ventilation is failing and the baby requires pressures much higher than 25, then if your high frequency ventilation mode of choice is the oscillator, you should start with a low frequency to prevent air trapping. And we recommend starting with a rate no more than 5 to 7 hertz. The minimum pressure that you're going to use, it's whatever it needs to be to keep the lung open, as we mentioned before, looking at the oxygenation and looking at the chest X-ray. The minimum pressure is usually 2 centimeters of water higher than the minimum pressure that the baby required when he was on conventional ventilation. The amplitude that you're going to use, it should be enough to control the PCO2 in normal range. Again, you don't need to bring the CO2 to 40. As long as your PCO2 is 50 or low 60 with a pH of 7.20, slightly higher, it's all you need. But no matter what your CO2 is, try to avoid going on an amplitude more than 3 times the minimum pressure because the risk of air trapping goes up exponentially after that. If you're lucky enough to have the jet, as we do, and you're very familiar with the jet, then that's what we do. We switch from conventional to the jet when the baby fails the conventional. We use low frequency of 240 breaths per minute, again, to prevent air trapping, which is quite common in these babies. We use a PEEP enough, again, to maintain lung volume. And this PEEP usually is about 1 or 2 centimeters of water higher than the PEEP that baby was requiring on conventional ventilation. The PIP that you're going to use on the jet, it's whatever PIP takes to control the CO2. And don't get scared by the number that you're going to need. Even if it's 30 or 40, remember that 30 or 40 is not what the alveoli is seeing. It's just the upper airway that is seeing that PIP. But the alveoli is seeing a much, much lower PIP because there is significant attenuation with high frequency ventilation. So don't worry about the number that you see on the jet to maintain the CO2, even if it's in this high 30s or 40s, that's okay. That's not what the alveoli is seeing. Again, because of the risk of trapping, try to avoid using side breath. If your oxygenation falls after you put the baby on just PEEP, you may need to go to a higher PEEP to maintain lung volume. And you can do that by applying some backup breath, side breath for 2 or 3 minutes. And then as soon as the lungs are reopened and re-expanded, you can try to remove those side breaths and see if you have can maintain the lung volume with PEEP alone. In terms of sedation and analgesia, I think some of the previous speakers talk about this. We try to recommend pre-medication before intubation if possible. It's extremely, extremely important to try to maintain spontaneous respiration. Paralyzing these babies routinely is not indicated anymore. The only time we recommend paralysis is when you are really against the wall, you cannot ventilate, you cannot oxygenate, cases of severe diaphragmatic hernia with severe hypoplasia that you may have to paralyze the baby to get control of the ventilation. Otherwise, we usually promote spontaneous breathing and we use very gentle sedation in the form of morphine infusion or fentanyl infusion at a smaller dose and try to avoid boluses, okay? Because these narcotics, as you know, have a lot of side effects. So try to use the minimal dose of sedation that will allow you to control the baby. Again, selective neuromuscular blockade only to those with greater ventilation or oxygen requirement. And if you're going to use paralysis, use it lightly, okay? Give a dose, and as soon as the baby starts waking up from the paralysis, see what the baby does. If you are not affecting the oxygenation or the ventilation, try to promote spontaneous breathing and only give another dose of paralysis when, again, you lose control of the ventilation of the baby. Again, minimal handling, cuckooing, swaddling, it's extremely important to minimize the amount of sedation that you need to give to these babies. Remember, these babies have a component of vasoreactivity in the pulmonary circulation. And if you start handling them too much, that's going to create vasoconstriction and worsen your oxygenation. The time of surgery, I think Dr. Retrosi touched a little bit about that. We usually wait until the degree of pulmonary hypertension has significantly improved. That in some babies may take 2 or 3 days. In some babies may take up to a week or 10 days. That's a decision that you have to make together with the surgeon, and always following TN echoes and see how the pulmonary hypertension is progressing. Okay, but sometimes you won't be able to wait until all the pulmonary hypertension is correct, because these babies, as I said before, have some fixed component of pulmonary hypertension that won't resolve. So you can't really wait until there is no pulmonary hypertension. Sometimes if you see that it's not progression anymore and you're ready on day 5, 6, you may have to go in. In general, what we do after the surgery is we keep the continuous suction to keep the gut decompressed by using an oral nasogastric 8 or 10 French tube. We keep the baby NPO until the return of the bowel function. We keep more or less the same management as we did before the surgery in terms of fluids and initiation of TPN. Nutrition is extremely important in these babies, so you shouldn't delay TPN. As soon as these babies are admitted to the unit, we start TPN, and we continue that TPN after surgery, and we don't actually stop it during the surgery. The aim is always try to maintain good perfusion, and you can measure that by looking at the urine output. It should be more than 1 ml per kilo per hour, and also looking at the blood lactate, that ideally you should try to keep it below 3 millimoles per liter. Most surgeons will ask you to cover the baby with antibiotics for at least 24 hours if there is no patch. And if they had to put a patch, they usually ask for a longer antibiotic treatment. That should be discussed with your surgeon, because they are the ones that decide for how long they want to keep the antibiotics. In terms of ventilation, we recommend keeping the same mode of ventilation that the baby went to the OR with. There's no reason to switch right away. Now, most of these babies will improve after surgery within 24 to 48 hours. The idea is to maintain the same approach to ventilation. Always try to avoid aggressive ventilation. Try to always aim for gentle ventilation. Try to keep your PIPs less than 25 if possible. Post-surgery now, your pre-ductal saturation should be around 90 to 95, low 90s. Again, there is no reason to keep the SATs in the high 90s. Low 90s is more than enough, even in babies with significant PPHN. Permissive hypercapnia, keeping the CO2 between 40 and 65, as long as your pH now is over 7 to 5 after the surgery, is more than appropriate. So don't aim again for normal pHs or normal CO2s. Because remember, you may be dealing with just one lung only, or 1.5. So you can't expect you have a CO2 of 40 and a pH of 7.40. It's true that after surgery, because of all the manipulation done during the surgery, that you may need slightly higher mineral pressure to compared to pre-surgery to open up the lungs. But when the lungs are reopened and re-expanded, you should be able to go back to the mineral pressure that you were using before, or sometime less, because you don't have the bowel inside the chest anymore. Okay, and that should be guided by your pulmonary graphics and chest X-ray or lung volume, lung ultrasound, if you have the ability to do that. The ventilator should be weaned, as we all know how to do that appropriately. Again, it depends the degree of pulmonary hypoplasia. It will also depend of the degree of hypertension, but most of these babies should be able to be weaned off the significant sedation over 2 or 3 days. And at that time, you can assess how effective the spontaneous breathing is for the baby to be able to maintain oxygenation and ventilation on their own. Again, we recommend when you are ready to extubate, always to extubate to some form of non-invasive ventilation, either a nasal CPAP or NIPPV or SNIPPV, as we are going to discuss in my next talk, according to what you use in your center. In terms of sedation, analgesia, and paralysis after the surgery, again, we always try to maintain spontaneous respiration. Try to avoid paralysis at all costs, and only use it when you have nothing else to offer and you can't really control ventilation oxygenation. Continue with morphine and fentanyl infusion. We are aware that after the surgery, the baby may need a slightly higher doses because of pain management, but that should start slowing down after 24 to 48 hours. So you should try to wean your narcotics after really 48 hours. One thing that we sometimes do to minimize exposure to narcotics is to use IV Tylenol to minimize the doses of narcotics that we are using. As I said, we usually start or try to wean the narcotics after 48 hours after the surgery. Now we use dexmedetomidine, which is a selective alpha-2 agonist that usually help us to wean the narcotics a bit faster. And then when the narcotics are completely off, we start weaning the dexmed soon after that. Again, minimal handling is crucial as before surgery. Now, one of the things that is done routinely after the surgery is an X-ray. When the surgeon removed the bowel from the chest, right after surgery, the lung on that side will remain partially collapsed. So that pleural space will be filled with air. That is not a pneumothorax, okay? So there is no need to put a chest tube in that air-filled chest. This is completely normal. As long as you don't have significant hemodynamic compromise, so you don't have significant mediastinal shift, this is something that is going to resolve by its own. So you don't have to do anything about it, okay? Now, when this air start reabsorbing and the lung on that side start expanding, then all of a sudden you're going to replace this air with fluid. And this is what you're going to see after 2 or 3 days of the surgery. Now, on that side, you're going to have a fluid, which is completely normal also. As long as you don't have significant mediastinal shift, that fluid is going to be there for some time, and you don't need to do anything about it. And that fluid will decrease as the lung continues to expand, and this fluid continues to be reabsorbed. Eventually, it will disappear completely, but it may take some time. And again, you don't have to drain this fluid. Now, I'm going to talk to finish more specifically about some specific phenotypes in terms of ventilatory management. Not all the diaphragmatic hernias will behave the same. We have cases in which the main issue is significant hypercapnia and hypoxemia. When you have both of this, significant hypercapnia and hypoxemia, one of the things you have most likely is significant atelectasis or consolidation. In that case, you need to open up the lungs. So if you're on conventional mechanical ventilation, you may need to increase your TI to 0.4. You may need to increase your volume to 4.5 or 5 mL per kilo until you reopen the lungs, those areas of atelectasis. And if that fails and you need very high pressures to be able to accommodate that volume, you may have to switch to high frequency ventilation. If you are already on high frequency oscillatory ventilation and you're having significant problem with atelectasis and consolidation, one of the things you need to do is you need to increase your mineral pressure to open up the lungs again. If you do that, then you need to bring down the frequency. Use very low frequency, 5 to 6, to prevent air trapping. And again, the amplitude you're going to use to control the CO2 is always 3 times or less the mineral pressure. If you're on the jet, again, you have to increase your mineral pressure. And the way you increase your mineral pressure on the jet is by increasing your PEEP, okay? And you do that until you obtain good lung volume. Frequencies, again, should be low, no more than 240, 280 to prevent air trapping. Now, in some cases, what you have is only problem or mostly problem with CO2. And your oxygenation is fine. You may be on 25, 30% oxygen, but you're having trouble getting rid of the CO2. In these cases, most likely what you're dealing with is with air trapping or significant secretion. So in this case, if you are on conventional ventilation and using ACVG, you need to decrease your backup frequency to improve your air trapping. If your baby is breathing very fast, you may have to increase your sedation to allow the baby to slow down his own spontaneous breathing. And also, you should consider decreasing the PEEP if you have significant air trapping due to excess PEEP. And also consider decreasing the TI to allow more time for the expiratory time and empty the lungs. Now, if you are on SIMV VG, what you can do is you can decrease the frequency to about 20 to 30. You may need to increase your VT if you do that to maintain your minute ventilation. If you are on high frequency oscillatory ventilation and you're dealing with significant air trapping, you have to consider decreasing the minute pressure and decreasing your frequency to the lowest level, which is about 5 to 6 hertz. The amplitude, again, if you're using more than 3 times the minute pressure, you should decrease that. And again, if doing all this is not fixing your air trapping, you may need to move to a different mode of ventilation. If you are on the jet, again, you have to consider decreasing the PEEP. That may be the reason that you have air trapping. You for sure need to slow down your frequency to the lowest point in the jet is about 240 breaths per minute. And if you're using side breath, you need to remove the side breath, which are usually significant contributors of air trapping. And the PIP, again, that you're going to need to use, you don't need to worry about it. You have to use enough PEEP to control the CO2. Now, in some cases, your main issue is not CO2, it's oxygenation. In this case, what you're dealing with most likely is just primarily pulmonary hypertension or PPHN. If you are on SIMV and ACVG, then you need to decrease your PEEP to 5-6 to minimize a compression of the capillary beds. You need to slow down or decrease your tidal volume. Maybe you may be overexpanding the lungs, and that may contribute to worsening the pulmonary hypertension. You need to bring down and shorten your TI also to no more than 0.3, 5, or 0.4 at the max. And also, if you are still not happy with oxygenation after doing all this, you may have to switch to high frequency ventilation that has proven to create a more uniform lung expansion that will help you to use nitric oxide and hopefully decrease the pressures in the pulmonary circulation. So if you're on high frequency oscillation, again, use relatively low minimal pressures, low frequencies, and amplitude less than 3 times the minimal pressure. If you're on the jet, again, use low PEEPs, of course, adding inhaled nitric oxide to see if the babies will be responding to nitric oxide or not. Use moderate frequency. You don't have risk for trapping here, so you can speed it up a little bit, and that will help you a little bit to bring your CO2 down. And again, enough PEEP to maintain your CO2. And I think that was my last slide. So I'm open for any question that you may have for me. Thank you.
Thank you very much, Dr. Alvaro, for this very important and practical lecture. So maybe I can have some question from the audience. So the first question, how much VG is allowed in cases of congenital diaphragmatic hernia? I think maybe they mentioned how high they can go with the VG.
Well, it depends. Again, you have to start with a volume, let's say, of R per kilo, because you have to start somewhere. But it will depend a lot on what kind of PIPs the machine is measuring. As long as your PIP is less than 25, you can keep going up on the volume. But as soon as you get a pressure of 25, between 25 and 28, you have to think about other form of ventilation. So we start with 4. You can go up as long as your PIP is not too high.
Okay. The second question, they said in this approach, you mean on the to keep the baby in the hypoxic side, especially in the after delivery. So what about pulmonary hypertension as a result of this relative hypoxemia? So do you think like allowing those baby to be hypoxic will complicate their pulmonary hypertension?
I don't think so. I mean, it's not ideal, but it's a compromise. Remember, you have to allow for a smooth transition, which is already difficult in these babies. So I think the worst thing you can do is try to hammer the lungs, try to aim for SATs that it's going to be very difficult to get SATs in the 90s or CO2s in the low 40s without using very high pressures. So the idea is to compromise, try to protect the lungs as much as you can, and try to slowly allow saturation to go up very slowly over an hour, 2 hours, okay? You may be right. Again, there will be some component of pulmonary hypertension, but as long as your ventilation is appropriate and you are allowing the baby to transition smoothly without applying very high pressures, eventually the reactive or reversible pulmonary hypertension is going to start getting better as the time goes by. And that's when you're going to see the SATs going from 80 to 85 to 90 to 95. But you don't have to rush it. That's my point. Don't try to aim for those SATs in the first 5 minutes of life, because that's extremely difficult and dangerous.
Another question, can we send baby to OR on high frequency ventilation?
Yeah, we do it all the time. Again, it's a lot up to the surgeon. They don't like to do the surgery when the baby and the chest is shaking like this. But our surgeons are very comfortable with that. They got used to it. So we send most of our babies when they need high frequency on the jet. If the baby needs a jet, we don't try to switch them back to conventional. If the baby has failed conventional and it's on the jet, then we don't try to put it back on the conventional just because of the surgery. We keep it on the jet.
Okay, another question, can we use can we use I to E ratio as 1-to-1 in baby with diaphragmatic hernia?
I wouldn't recommend that because if you use a 1-to-1 ratio, very likely you're gonna get air trapping. And a TI of 0.5, 0.6 is gonna be too long for these babies. Remember, the compliance is not a big issue here. So you don't really need to use very high inspiratory time. Most of the time, a short inspiratory time is more than enough. So there is no reason to aim for a 1-to-1 ratio, because you're gonna get more barotrauma, volume trauma, and also risk of air trapping.
Another question, what is the acceptable saturation after the surgery?
Well, I guess after surgery, you expect this baby is the pulmonary hypertension will be significantly better, and that's why you send the baby for surgery. In that case, you should start aiming for SATs in the low 90s, as I said. Again, the SATs in the 80s are only good for 2 or 3 hours. Keeping the SATs lower than 90, again, is not going to help you with your pulmonary hypertension. So after just the first few hours of life, we recommend aiming for SATs in the low 90s, and that should be the same after the surgery.
I have a question. Like we know surfactant therapy is not recommended, but if you have a preterm baby, like let's say 33, 34, and you will consider giving surfactant, what the dose you will give?
Right. No, yeah, of course. If you're dealing with a preterm, you may have surfactant deficiency and congenital pulmonary hernia. In that case, of course, surfactant is indicated. I was just talking about a term baby with pulmonary hernia. In a preterm, Now the dose, your guess is as good as mine. It depends how much line do you think you have, but I would list at least 2/3 of the total volume, at least. So 5 per kilo will go maybe 3.5 to 4 per kilo. Giving a bit of extra bless or surfactant is not going to harm much.
Okay, another question. If the issue is hypercapnia and I reduce the frequency, the baby will return. Will have more CO2 retention. Is that right?
No, depends. On the oscillator, when you decrease the frequency, you're actually increasing your minute ventilation. So by decreasing the frequency in the oscillator, your CO2 removal will improve. Okay. Now on the jet, yes, when you decrease your frequency, your minute ventilation will go down. But remember that the equation for minute ventilation on high frequency is frequency times tidal volume square. So the influence of the volume, the tidal volume on the medium ventilation is way, way higher and stronger than frequency. So don't be afraid to decrease your frequency. You may have to increase your PIP a little bit if you're on the jet to compensate for that slight drop in medium ventilation, but it shouldn't really give you a big trouble with the CO2 by decreasing the frequency.
Thank you very much. I think the second moderator will moderate